Hello, welcome everyone. I can see we've got 17 people in the room. So yeah, welcome to the session. So I think we'll just give it another minute or so, and then we'll get started as there's quite a bit to cover. But yeah, thanks for joining everyone. Right, 7:02. I feel like we'll make a start as there's quite a bit to cover, but this is being recorded, so after the session anyone could basically access it if they just go on the recordings. But so yes, I'll start our slides then. So yeah, welcome to today's session. So today we are teaching paediatrics, and this will be a part 1. We'll cover some more topics in part 2. So I'm Vicky, an F1 doctor at Eastbourne, and we also have Tess.
Hi, I'm Tess. I work at Conquest Hospital.
So yeah, let's get started. So just before we start, a little bit about our organisation. So Thursday 15 is basically the name of the final series, and basically we try and base our sessions around MCQs. So we'll start off the session by doing 13 MCQs, and we'll then cover all the answers at the end. We're doing them on Thursdays, as hence the name, but also on Tuesdays as well, because there's quite a few topics to cover under the umbrella of finals / also relevant for any other year group, really. But overall, our overall organisation is called MedTech Teaching. We also run like prescribing safety assessment courses, and we have plans for other types of sessions as well, but the main ones are the prescribing and the final series. So what are we actually going to cover in today's session? So the main topics today are respiratory. So we're going to do a bit of revision over causes of shortness of breath, wheeze, cough, stridor. Then in terms of abdominal stuff, we're going to look at more of the acute side of the abdominal pain, and vomiting differentials, which I know doesn't sound like a lot, but actually I think it's a really, really important area to get right, because it's all of these topics are very high yield. And then we'll also cover a bit of neuro, looking at funny turns and headache. And on to the next. So on to our MCQs part of the session. Tess, how long are we going to time them for? Because I know you've done this.
I think last time we did about a minute per question.
Fab. Okay, so we're going to time you a minute per question. So if you just grab a pen and paper, or you can type on your phone as well. So just get ready. We're going to just go through each of the questions and we'll switch after a minute. But don't worry if you can't come up with an answer. We're going to go through it all at the end. Just give it your best shot. But it just means that we get the session moving and cover things. So without further ado, hope everyone's ready to get started. So get my timer ready. Okay, and this is the first question. So timer starting now. And I'm moving on to the next question. Second minute's up, moving on to the next question. Moving on again. Now on to question 5. Nearly halfway through, on to the next. Okay, we're halfway through now. Next question, nearly there. On to question 9. To question 10. Question 11. Very nearly there. Next question. Okay, and last question. Okay, and that is time. Well done. Smashed it. Thanks for bearing with. So I think what we'll do at this point then is go through the answers. But yeah, have a breather. Well done for getting through all those. But yeah, Tess, if you want to take it away with the first explanations.
Absolutely. So what we'll do is basically if people can just put their answers in the group chat, and then we'll discuss. We're going to do questions 1 and 2 together because they're both about sort of a wheezy, short of breath child. Don't worry if you've got the wrong answers. That's the whole point of this talk. If you knew everything, there'd be no point doing it. So yeah, can we go to the next slide? What diagnoses have people got for this question? Any suggestions for what they think is happening? Okay, we've got lots of E's, so viral induced wheeze. Okay, so just click on the next slide for me. Yeah, absolutely. We'll talk about why it is. But the sort of the symptoms and the fact that she's got these sort of episodes that are where she's well in between them is very sort of typical of your viral induced wheeze. So if you go to question 2. Here it's looking at again a wheeze and shortness of breath child and what's the most appropriate treatment for this case. So anyone got any ideas what they think's going on and how would they treat it? So lots of D's. So the slightly lower dose IM adrenaline. If we go to the next slide. So that's absolutely correct. As you're clearly got here, this is a case of out of hospital anaphylaxis, probably caused by sort of something in the garden, maybe a bee sting or something. And she's got quite a strong atopic history in the family, so she's likely to have her own allergies. The rash and the swollen lips make that more likely than something like asthma, and based on her age, that's the right dose. So if we just go to the next slide. So on this slide, I've just summarised the sort of differences between asthma, viral-induced wheeze, and bronchiolitis. There's quite a lot of overlap both in the pathophysiology and the sort of presentation. So bronchiolitis is the smaller children. It's got sort of a cough, poor feeding, and it lasts up to 10 days, and it's actually usually caused specifically by the RSV virus, which in adults would just cause sort of cold-like symptoms, but because in babies they have much smaller airways, any kind of sort of constriction is going to cause this wheeze and crackle for them, so we don't really notice it now with our big airways. Viral-induced wheeze is seen in slightly older children. It's very, very similar in presentation and management to asthma, but it's always associated with infection, and they are usually well in between. So they don't have sort of other triggers like exercising, allergens. They don't have a cough that's worse in the morning, etc. And with asthma, you need to be sort of over 5 to be able to do the sort of spirometry and peak flow things required for diagnosis. Okay. Bronchiolitis is managed slightly differently to viral-induced wheeze and asthma. Mostly it's sort of self-resolving and can just have supportive care. So give them small and frequent feeds because they're going to struggle to breathe through their nose whilst they're eating. You can give them saline nasal drops to help, and always safety net the parents to bring them back if there's any issues. But sometimes we might have to admit them to hospital for oxygen, some nutritional support if they're not able to feed up a sort of 50% of their normal intake. Other reasons to admit is if they have risk factors for very severe bronchiolitis, so premature babies, babies with underlying lung or heart conditions, they're at high risk of getting more unwell. And generally, if the parents are worried, we admit babies with bronchiolitis, just sort of to be on the safe side. So if we go to the next page, so this is just a quick overview of how we manage acute asthma, which, like I say, is actually similar for the way we treat viral-induced wheeze. In the community, you might only have salbutamol inhalers. You need to give that with a spacer, and then get into hospital if that's not controlling their symptoms after 10 puffs. In A&E, we can give bronchodilators via nebulizers, so something like salbutamol, and then ipratropium is usually added. And then we can give steroids as well. It's important to give them early on in acute asthma. I've just popped the prednisolone doses by age on the screen there. It can be really useful for your exams to remember to learn the sort of acute, severe, life-threatening criteria, because they do like to ask things like, what is the severity of this asthma attack? But generally, you're going to want to assess their news score, their peak flow. Peak flow is very important for saying severity. You're going to listen for wheeze. You're going to do an ABG, and if that CO2 is normalising, that's life-threatening. Okay. Any questions about asthma before we move on to anaphylaxis? In answer to the question in the chat, yes, I think you do get access to the slides or a recording after this if you fill in the feedback. Okay, so let's move on to anaphylaxis now. Brilliant. So anaphylaxis cannot often be confused with things like asthma, or if you're looking at the sort of the blood pressure, people might think the patient is septic, but you're going to see wheeze, possibly itching and hives, swelling of the lips especially. In proper anaphylaxis, you've got this rapid onset with airway, breathing and circulation compromise, so it's a do not miss differential. You need to get senior help immediately. Lie them down, improving blood supply to the brain. Remove any triggers, so if it's an antibiotic that's sort of running into their cannula, detach that. And then the treatment is IM adrenaline. So in the question, I think she was an 8-year-old, so that puts her in the 6 to 11 category, where you give 0.3 milligrams of IM adrenaline. You're also going to want to give them chlorphenamine and hydrocortisone, and you keep them in for observation about 6 to 12 hours, because they can have a biphasic reaction where they go back into anaphylaxis. Okay. And then when a child's discharged, they need to be seen, like followed up by both their GP and also in the paediatric outpatient clinic. And they need to be given education, so spotting the signs, how to avoid allergens, using an EpiPen, and possibly sort of how to do paediatric BLS. Okay, so I think that's everything for anaphylaxis that I wanted to cover. So let's move on to question 3. So here we've got a coughing child. We've moved on from wheeze to coughing fits. Has anyone got any ideas what the treatment might be here, or what the diagnosis is and therefore the treatment? So we've got C, and someone said it's whooping cough, and therefore you use a macrolide such as clarithromycin. Brilliant. So if we go on to the next slide, it absolutely is a whooping cough, but if we go on to the next slide, you'll see why no medication is required in this circumstance. So we'll talk about a little about what whooping cough is in a second, but basically this patient has had the symptoms for 6 weeks, so it's not within 21 days of symptom onset, and therefore we don't give the antibiotics, but otherwise it would absolutely be the correct answer. So if you just go back one slide, so she's got these coughing bouts, coughing so much she's vomiting, but it's been going on 6 weeks, so actually there's nothing to do sort of medication wise in this case. So if you just go forwards again, whooping cough is caused by the pertussis bacteria. Usually you're vaccinated, but this patient didn't have her childhood vaccines, and it can give you these sort of paroxysmal, so sudden onset coughing bouts with this very loud inspiratory whoop noise, and they might cough so hard that they vomit or they faint, or in infants they might have apneas. Okay, it can last 2-3 months, and it's highly contagious, so it's a notifiable disease. It's diagnosed based on the symptoms, having them for more than 14 days, and also a positive swab. And school exclusion is either 48 hours from when you start antibiotics, if you're going to give them, or 21 days from symptom onset. So this child can go back to school if she hasn't been there. If it's a child under 6 months, we need to admit them because it can make babies very ill. Okay. We will cover some other causes of cough a little bit later on, like croup. But if we just go to the next slide, I've just got a summary of chronic asthma management. So we've covered sort of the acute asthma, but chronic asthma patients are most likely sort of symptom is that they're going to have a cough, and maybe a bit of increased work of breathing with exercise, that kind of thing. The diagnosis is hard to make in children under 5, so often we can just like treat them if we suspect it and observe whether that improves their symptoms. But for children over 5, they should be able to engage with spirometry and see if it's reversible with bronchodilators, or sometimes you can do pheno testing. In that black box at the bottom, I've just put the sort of the criteria, so it needs to, on spirometry, it needs to show obstruction that is reversible. Okay. If you do decide to give a child an inhaler, it's important that they actually have the correct inhaler technique and that they're given a spacer. And if it doesn't seem to be working, you wait 4 to 8 weeks before you sort of move up the ladder. I've put the 2 ladders here, so there's sort of one ladder for the under 5s and one for over 5s, which is pretty much the same as the adult ladder. It's something to learn. It's good to learn examples of brands as well, because we always prescribe inhalers as sort of the actual brand as well as the constituents. If there are, the GP can make these diagnoses, although you're usually referred to a paediatrician. You might need specialist advice or additional investigation if the diagnosis is unclear or they're not responding as expected to asthma treatment, or if there's a severe life-threatening asthma attack. they always need to be seen in follow-up clinic by paediatricians. You move up a step in the ladder, just like adults, if they're using the reliever inhaler 3 or more times within a week. And you can move back down to a lower step on the ladder to find the lowest controlling therapy, because we obviously don't want to give kids more medications than they need. Okay. If we just move on to the next slide. So another cause of cough that we're covering here is pneumonia. So kids can absolutely get chest infections like adults. The causes are slightly different in terms of like what's most common for kids, but the most common is strep pneumoniae. And I've popped some other ones on here, including some viruses. If they are under 5, they are at risk of getting more unwell, so we should advise parents to call 111. And if they're exposed to smoking or they have a sort of past medical history that puts them more at risk of getting unwell, they should be seen in the paediatric assessment unit. Symptoms are very similar to the symptoms you get in adults, but you might also see things like sweating, reduced feeding, irritability, dry nappies. If someone's getting recurrent chest infections, a child, you're going to do a number of investigations, including chest x-ray to look for structural abnormalities or foreign bodies, or potentially even a cancer. You're going to test them for antibody deficiencies. You can also test them for something called Ig class switch recombination deficiency, which is basically where they can't form long-term immunity to pathogens. You might consider doing a sweat test to test for cystic fibrosis, which we'll cover in a bit, and you can also consider an HIV test. Okay, so if we move on to the next slide, so directly linked to my last point, this is a case of a child with cystic fibrosis. The parents are both carriers, and this is asking what's the chance of them having another child with cystic fibrosis. Yeah, you guys are smashing it. So if you just go on 2 slides on for me. Yeah, so it's an autosomal recessive disease, so there's a 25% chance of 2 carrier parents having an affected child. It affects multiple systems. We often think about it in just sort of the context of the respiratory problems, so recurrent infections, bronchiectasis, etc. But it's also going to affect things like the pancreas, causing pancreatic insufficiency symptoms, including diabetes, failure to thrive. It can affect the abdomen and the biliary tree, causing obstructions, stones, or in a newborn meconium ileus, or rectal prolapse. And unfortunately, as the child becomes older, it can become apparent that the reproductive organs are affected too, resulting in reduced fertility. Basically, you have a mutation that affects your chloride and water movement in and out of cells, and that causes these thick secretions. In the sweat glands, it also results in very sort of chloride-heavy sweat, which is why we can do the sweat test to diagnose. But it's also part of the newborn screening heel prick blood test. So often cases are picked up very early on. But if not, we can do sweat test, and then things like genetic tests can be done for the parents as well. Other investigations are sort of looking at these key problems that cystic fibrosis can cause. So you can look at the lung function, bloods, look at the pancreas. You can do fecal elastase, fasting glucose, etc. You might do some chest imaging, and if you're worried about obstruction, you need to do some abdo imaging as well. So if we move on, the next slide's about management. So unfortunately, you can't really. The only sort of definitive management is for the lung problems is a lung and heart transplant. So mainly we're just trying to minimise the symptoms, minimise the impact on life. So they need annual vaccinations and regular physical exercise to keep them sort of at their peak health, so to speak. Chest physio is really important to help them clear the mucus, these thick secretions. They might need prophylactic antibiotics or to stop these exacerbations and infections. Bronchodilators and mucolytics can also help. And then for the pancreas, if they've got pancreatic insufficiency, we need to replace the function of the pancreas essentially with enzymes and insulin. Nutrition is also very important to optimise, and they'll be managed by this big multidisciplinary team, and they'll have 2 specialist sort of visits a year. And every year they'll have pulmonary function testing, chest x-ray, sputum cultures, and diabetic screening. Okay. The big complications are massive hemoptysis or pneumothorax, but that's not going to affect every child, thankfully. Later on, as the children become older, they're going to need things like fertility counselling, as there are risks with pregnancy. Okay. So we're going to move on to the next question now, which is, I think, the last respiratory question. So this is now about a question about a child with stridor, which is an upper airways noise. She's got hoarse voice, fever, but news is stable, and she had some coryzal symptoms the night before. What do we think is causing this? So someone has suggested A, parainfluenza. Someone else has suggested D, Haemophilus. And someone else has suggested A. Okay, so we've got a 50% split between A and D, which is good because I'm about to go into the differences between the conditions. So if we just click next. So in this case, it's the parainfluenza, and we'll talk about that, why that is. Parainfluenza causes croup, and the other one, D, causes epiglottitis, which are very similar presentations often. RSV is the bronchiolitis one, and pertussis we talked about being whooping cough. So in this case, this is more likely to be croup, and that's because it would have these preceding coryza symptoms, and she's very stable at the moment and has a hoarse voice. If we go on to the next slide. So croup is, I mean, I would have given it away if I'd said barking cough, but that is often the key term they'll use in an MCQ. So they both have stridor and secretions or drooling, but in croup you've got a barking cough, a hoarse voice, whereas in acute epiglottitis, all that's muffled. Okay, and in acute epiglottitis, they're going to be very, very unwell. So I gave her a Pew score of 0, I think, or said she was stable. Whereas if it was epiglottitis caused by H. influenzae type B, they'd be unwell. They'd be tripoding, so like leaning forwards on the hands, and you'd hear these muffled sounds. Both of them might have a fever, so that's not super helpful. And like I say, croup has usually a prodrome before it. The affected age groups are slightly different. Croup tends to affect slightly younger children, and you're not going to x-ray these children, but if you did, you'd see something called the steeple sign in croup and the thumb sign in epiglottitis, but you shouldn't be, you wouldn't normally x-ray these children because you need to treat them instead. Croup is a lot less serious. It's usually self-limiting. They recover within 48 hours, but there is a risk of airway compromise, so it's important to involve seniors, keep the child as calm as possible. Do not do an ENT examination for either of these cases, and for the croup you're going to give dexamethasone, whereas for the epiglottitis you're going to give antibiotics as well as dexamethasone because it's a bacterial infection. Education for croup is sort of stay off school while the child's febrile, good hygiene measures, give them paracetamol at home, comfort them, give them fluids. They don't need to inhale any sort of steam or have any cold medicines. And if they're not getting better after 48 hours, or they get very noisy breathing, they need to be brought in urgently. Or if they sort of start struggling to breathe or they turn blue, like, call an ambulance. In the moderate severe cases, you might also give them nebulized adrenaline. That would be for patients with sort of very high fevers, a rest rate above 60, signs of respiratory failure, and also if they're sort of under 3 months old, you're going to be worried about them. Okay, so if we just go to the next slide, this is just the severities of croup: mild, moderate, and severe. So like I say, if it's just mild, give them the oral dexamethasone and send the parents home with education. But if it's moderate or severe, you need to make sure that airway is going to be protected and add nebulized adrenaline. And then if we go on to the next slide, so a final cause of stridor might be a foreign body. This is commonly in the NCQs is going to be a younger child or someone with learning difficulties. The carer reports them playing with a small object, and sudden rapid onset of choking, coughing, gagging, might be short of breath. You might hear them coughing, you might hear a stridor on auscultation or a unilateral monophonic wheeze. They're likely to be a bit hypoxic and to have diminished breath sounds on one side. If they are conscious and it's in the community, you encourage them to cough and you can give them some back blows. If that's unsuccessful, you give abdominal thrusts, or if it's a less than 1 year old, you give them 5 chest compressions. And then if that's successful, you send them to hospital. If that's unsuccessful, or the child and you need to call 999 and continue doing your back blows, your chest thrusts or abdomen thrusts. And if they lose consciousness, you need to start CPR. Okay. But if they are calm and they are okay, don't distress the crowd. Call all the airway and paediatric magicians to come secure the airway. And then you can do a chest x-ray to confirm and remove the foreign body with a flexible bronchoscopy. Okay. So before we move on to neuro, has anyone got any questions about any of the RESP conditions we've just done a whistle-stop tour of? If anyone thinks of anything later, feel free to put them up. So if we go on to question 6, so we are now in neuro land. So this is a child with a shaking episode, or a funny turn, or a seizure, whatever you want to call it. And that's in the context of a fever, and this is the first time it's happened. No sort of very interesting family history at all. Not a very interesting examination. Slightly raised CRP, which fits with her having a fever. So what do people think's going on, and what sort of action would they take next? Someone suggested D. Someone suggested it's a febrile seizure and that therefore they would give safety advice and paracetamol. Okay, looks like the consensus is D, which is exactly the answer I was going for. So if we just go on. So if we go to the next slide, this was, if you look at the febrile convulsion sort of table, this is a young child with a high fever who's had what classes as a simple febrile convulsion, so generalised tonic-clonic that lasted only a few minutes and has happened only once. And because this is the case, they are unlikely to have any lasting damage, and as long as we sort of control the fever, manage any underlying infection, no further investigation is required. But you do need to give some safety advice for parents on what to do if there is another seizure in the future. We call febrile convulsions complex if it's, a partial or focal seizure, if it lasts a long time, or if it happens several times within the same illness. When would we think about epilepsy? Sort of, it's about the circumstances. So they'll usually have more frequent seizures, not necessarily in the setting of illness. They might have lasting neurological symptoms afterwards. And there are lots of different triggers: illness, stress, alcohol, tiredness, etc. So if we do think it's epilepsy, because they haven't got a fever or it's happened lots of times, we need to investigate with EEG, MRI, electrolytes, cultures, LP, thinking about sort of our encephalitis, meningitis differentials, and then they may be started on anti-epileptics, or if they're in status epilepticus, benzodiazepines, just like for adults. Okay, if we go on to the next slide. So this is more OSCE related than MCQ, but if a child has had a febrile convulsion, and you're confident in that from your history, you need to explain that to the parents, reassure them, and tell them if a seizure happens in the future, they need to stay with them, put them somewhere safe where they're not going to injure themselves, ideally in the recovery position. Don't put anything near their mouth, and if it lasts more than 5 minutes, they need to call an ambulance. And if it's self-terminating and they don't call an ambulance, they still need to be seen by their GP ASAP. Okay. Yeah. Okay. Next question. So this is a teeny tiny baby now. What treatment would we like? I should say, I think we're in hospital in this question. So we're getting some D suggestions here. D, yeah. Yep, so if we go on to the next question. The next slide, sorry. So this is a case of bacterial meningitis. We're suspecting that already from the history, so they're not feeling well, lethargic. A bulging fontanelle is like a key word to look out for in your MCQs, and she's feverish. It's a bit hard to know what's going on with a child, like a baby with fever. It's often very non-specific symptoms, just not feeling well. But we've done an LP, as most babies would have in this situation, and it's showing cloudy fluid, which suggests it's bacterial. It's high protein and low glucose, because the bacteria is eating the glucose essentially. So we're thinking it's a bacterial meningitis, and this child is 2 months old. So if we go on to the next slide. Have I not put the the treatment's on the next slide. Okay. So I've just summarised the sort of key symptoms you might see here in children versus babies. You do a lumbar puncture in any baby less than a month old who has a fever. If they're 1 to 3 months old, you do an LP if they're unwell with the fever. And if they're less than 1, if they've got features of serious illness. Other investigations are the Koenig's and Budzinski's signs. And you also, when you do your lumbar puncture, you want to look at their bacterial culture, viral PCR, cell count, protein, and glucose. Most common causes in children are sort of Neisseria meningitidis and Streptococcus pneumoniae, but in neonates it's group B strep that they get from during childbirth. And in terms of viruses, it's HSV and varicella and enterovirus. Okay, so if we go on to the next slide, this is where I've got the management. I got confused there. So adults, I think, get ceftriaxone like the over 3-month-year-olds, but this was a 2-month-year-old baby, which is why we've given cefotaxime and amoxicillin as our antibiotics. And then you also want to give steroids to try and protect from neurological damage. And if you're considering that there's penicillin resistance, you add vancomycin. That's in the hospital if we sort of know what's going on. In community, if you've got an unwell child, you need to give them benzyl penicillin, because that's what they have in the GP surgery, and then transfer them by ambulance. Okay, and notifying public health was actually one of the question options. That is something you need to do, but it's not the most urgent thing, of course, because you've got an unwell baby in front of you. If it's a viral case, they often just need sort of supportive management, but you do want to do a viral PCR to try and determine that, and then you can give a cyclovir if it's an appropriate infection. It's not super clear, but I've stolen this table from the Zero to Finals website. It just summarises bacterial versus viral CSF from a lumbar puncture. If someone has been in prolonged close contact with someone that has meningococcal infection in the sort of 7 days before they got ill, it's important to give them post-exposure prophylaxis, which is usually a single dose of ciprofloxacin. And like I said, the babies, the neonates, are likely to have group B strep, which is why we add in the amoxicillin. That was why that was the correct answer for this question. Okay, any questions about meningitis? We'll move on to the next question. So question 8. This is our final neuro question. So here we've got a 6-year-old with a headache that seems to be progressing, but otherwise well, and we couldn't really examine him. What do people feel they want to do? So a lot of people want to do E. You guys are, you know your stuff, very good. So if we go to the next slide, it absolutely is E. So sumatriptan might be appropriate if it's sort of migraine type headaches, but actually in a child, headache is almost always concerning if they're under 12. Children are more likely to get tummy aches rather than headaches, so there's often something else going on, and this sort of hasn't been described as a migraine type headache, so I wouldn't go straight for the sumatriptans. They're well, and it's been going on for over a week, so I'm not so worried about meningitis. I'm not thinking about an LP here. And if we go to the next slide, we'll talk about when we do scans. So if we just go to the next slide. Either I have lost connection or Vicky has. Oh. Let me try and present. What slide was it? Can people put in the chat if they can hear me? Okay, you can hear me. And are you guys seeing currently the paediatric headache guidelines? Amazing. Okay. I don't know what's happened there. We will carry on. So this is just taken pretty much from the NICE guidelines for paediatric headaches, and also Head Smart. Basically, an under 12-year-old with a headache that has any of these concerning features needs to have same-day paediatric assessment. So if it's waking them up or present in the morning, if it's getting progressively worse, like in the question, if it's triggered by coughing, sneezing, bending down, that's signs of increased intracranial pressure, Obviously, if the signs of meningitis, or then we're going to be concerned about meningitis. Anything like ataxia, changes in consciousness are concerning. Changes in vision, especially if they've got like a squint or unable to gaze upwards. And also in the context of a head injury, these patients all need same day assessment from a paediatrician. If they're under 4 and they have a headache, we're very worried. They need urgent neurological assessment, because like I say, it's not common for your smaller children to actually get headaches in the same way that F1s get headaches all the time. If you are suspecting a space occupying lesion, we'll look at that in a second, what sort of symptoms that might make you think that, they should have an MRI both done and reported within a 4-week period. That's the sort of guidelines. If a patient is having recurrent headaches, you've ruled out anything sort of sinister. All children with recurrent headaches should have their blood pressure checked and compared to sort of their age, and they should all have fundoscopy. So you're going to refer those children to. Okay, so if we go on to the next slide, I'm in charge of the slides. If we go on to the next slide, these are some symptoms that could suggest a brain tumour. It's much more likely if they have several of these signs together. So like I say, just having a headache is less likely to be a brain tumour, but if they have a headache and motor symptoms or visual symptoms or diabetes insipidus, that's when you become sort of more suspicious. It's important to ask about all of these symptoms, any predisposing factors like personal or family history of a known brain tumour or leukemia, early onset breast cancer in the family, any previous radiation to the central nervous system, or conditions like neurofibromatosis or tuberous sclerosis. All those can sort of predispose you to brain tumours. Symptoms can fluctuate and can occur in isolation or in combination, but like I said, just a headache with no red flags is rarely a brain tumour. If they've got a persistent headache in an under 4-year-old or a persistent headache that's waking them up, you do need to scan them within that 4-week mark. And unfortunately, there are some things that can sort of contribute to diagnostic delay, and those include social deprivation, low parental education, family, and those people would benefit from things like health visitor liaison services. If a GP is really suspicious, they should discuss their concerns with a paediatrician the same day, and refer them to a rapid access clinic. Okay, so that is, I don't know what's going on with the slides, but that is
moving on to presenting, so I can move the slides, don't worry, I'm on it.
You're on, right.
Yeah.
So that is a whistle-stop tour through RESP and a little bit of neuro. We didn't cover things like what am I trying to say, like developmental conditions or cerebral palsy. We can cover them in part 2 if people would like, but now I'm going to hand over to Vicky to do some abdo conditions. Thanks, guys.
Hello, sorry, thanks for bearing with. I'm not really sure what happened just then, but hopefully it will all be smooth plain sailing from here. So moving on to the first question of the abdo section. So can you please pop in the chat, what do you think might be going on here? So what do you think might be the most likely diagnosis of all these? Any answers? Stunned silence. Okay, well, we'll move on to the answer then. So
we've got some answers in the chat. People are saying D.
Oh, sorry. I don't know why it wasn't loading up for me. Okay, perfect. Well done. So, yeah, so that's the correct answer there. And does anyone want to tell me before I move on to the next slide why, out of all of these, the one factor, one actually key bit of history that makes you think this could be D. Sorry, I just scrolled up. Neonates, so yeah. And specifically within the neonatal period is being preterm out of all of these, out of all of this bit of history, because the bile staining, vomit, that could be a lot of these things. But because they're preterm, I'd say that's especially why in this answer, in this question, that neck is the answer here rather than the rest. And then also the other key bit of information there is also the meconium, passing of the meconium. So yeah, because she passed the meconium within 10 hours, that's normal. So I think that kind of rules out Hirschsprung's there as well. Yeah, so let's go into a bit more detail about necrotizing enterocolitis. So I think it's quite a useful condition to know about within sort of the abdominal differentials. I suppose the key thing here is that it happens mainly to preterm babies. So you can see here that NEC is an acute inflammatory disease affecting preterm infants. It can lead to bowel necrosis, multi-system organ failure, and is life-threatening. So that's why actually in those answers there, sepsis was an option, but the obs weren't quite there yet in terms of sort of indicating sepsis, but it could definitely be heading that way. And NEC was just a bit more specific there. So yeah, you can see here the stats show that NEC is very rare actually in term babies, and the whole sort of process behind why that happens is quite different in term babies. But yeah, 85% of NEC cases occur in infants who are premature, especially less than 32 weeks, and have a low birth weight as well. So in terms of what actually causes NEC, there's not really a specific answer. It's just due to a lot of different factors here. We know obviously that it's associated with being preterm. And yeah, so I've got this little diagram here which just shows basically a whole host of different reasons. But I think the key takeaway point is if you see bilious vomiting in a preterm baby, just have in the back of your mind NEC. So in terms of typical symptoms, so things like, new feed intolerance, the bilious vomiting, that's very important, distended abdomen, they might have fresh blood in their stool. And in terms of examinations, distended abdomen again, can be tender, reduced or absent bowel sounds, maybe an abdominal mass, visible loops, intestinal loops. And the skin, I didn't want to put a picture on here, but if you want to have a look yourself as well, just to get an idea, it looks kind of almost cellulitis-like on top of the belly if it gets to the stage where we're getting peritonitis. And then obviously just systemic signs indicating like in hemodynamic instability. And actually it can be quite difficult to diagnose NEC actually, as there's not really a specific examination finding basically which will help us diagnose it. It's just a combination of factors, and I think just based on the history you'll be able to differentiate between the different differentials here, but I think it was pretty clear in that question that this was the most likely. So in terms of investigations, there's a whole host of things that you can do there. So yeah, full blood count, CRP, CBG, blood culture. But I think the really key abdominal X-ray finding is this pneumatosis intestinalis. So that's bowel gas in this sort of intramural space. And that's actually pathognomonic for NEC. So as in, if you see that, we're pretty certain that it's NEC, basically. And so I've got a little image of what that looks like. So these are some classic X-ray findings that you might find in NEC, and examinable as well, I suppose. So you can see there, air under the diaphragm, and that can occur if there's bowel perforation, air in the portal tract. So I've been told it looks a bit like tree branches in the liver, sort of dark tree branches. And then you can get distended bowel loops, and then there's that intramural air that I was talking about, which is very pathognomonic for NEC, basically. So that's another key buzzword in there. In terms of management, it basically relies on what stage of neck. And I don't feel like you should get too bogged down in this detail. I'm basically putting this here just for sort of sake of completion so you know what happens. But there are basically lots of different stages of neck in terms of severity, and that basically determines what management we're going to have put in place. But for your own interest, if you're interested in neonatology, this is basically how they decide what we do. So yeah, if we're sort of looking more at Bell stage 1 and stage 2, so on the less severe end of things, we may not need to sort of have too invasive management. So you might just involve withholding the feeds, some IV antibiotics, and some just general systemic support. Once we're getting to stage 3 level, where it's maybe signs of perforation, you may need to have basic surgical intervention at this point, but hopefully you catch these before we reach that point. So yeah, that's basically neck in a nutshell. And I think, yeah, the key thing is just to know how to differentiate between the rest of them, because bullous vomiting can mean a lot of things, but it's looking at the general picture. What age group are we talking about? And that will just help you differentiate between the rest of them. And so my next section here is basically talking about vomiting differentials, and this will be useful for the next few questions as well. So excuse for the maybe overwhelming slide here, but basically this slide is just here to show you that it could be so many different things. So obviously there's like GI causes in themselves, but then there's also loads of non-GI causes as well that could cause vomiting, basically. So it's, I think, a really, really important presentation in paediatrics to get to know how to differentiate and to get right in your exams, because it's just, I think, very examinable, very important also in real life as well. So yeah, this is just to give you a picture of what could be going on, to keep your differentials broad, but obviously depending on the child in front of you, you can narrow things down a bit more easily. And then I just thought as well, so when you're trying to differentiate between vomiting differentials, there's a few, I think, key points to have in your mind when you're thinking, like what could be going on here? I think a classic one is, bullous or non-bullous. Is there blood in there? I think age of presentation is very, very, very important as well. Associated symptoms as well. And basically, when I was doing research for making these slides, I found a really good resource on PEDS cases. We'll share all the resources at the end so you can have a look yourself. And this, I thought, was a really good table which sort of showed what age groups and what conditions you expect at each age group, basically. I think it's very important to have this in the back of your mind with a lot of PEDS topics. It can, it's not just GI, but in any PEDS topics, just have in the back of your mind what age do conditions normally present at, and I think that will just help you organize your thoughts, because otherwise it is overwhelming. PEDS is just so much to remember. And then I went one step further, and this table is not complete. I didn't have enough time to feel like complete all of it, but I just thought as an idea, as a starting point, to make your life easier when thinking about vomiting, I think a table like this is quite helpful, because then you can just see, okay, right, what age are we thinking this is most common at? What are the key things that you're going to see in the history that are going to be able to make you differentiate between different vomiting causes quick? So, is it bullous, like I said? What's the stool like? Is there an abdominal mass, or is there a really key investigation or imaging finding that would be like, oh right, that's definitely pyloric stenosis, it can't be anything else if there's that finding on the ultrasound scan. So yeah, sorry I didn't get to finish all of this table, but I thought it's quite a lot of information is already there, and I feel like this would be like a good starting point, and you can make your own with the rest of the vomiting kind of conditions and presentations. So yeah, just a little idea there. And then this slide is just to basically enhance the point that, with the bullous vomiting, basically it's quite a good indication for you to tell you where the defect is. So you can see that this diagram shows that if you get bullous vomiting, basically it means that the problem is below the ampulla ovata, which is basically the entrance to the duodenum. So that the problem is below or above this line, depending on whether the vomit is bilious or not. So I just thought it's quite useful just to have the back of your mind just to help visualize where the problem is. Oh, sorry, and I will answer some questions in a sec. And here as well are some key concerning features as well. So if you see in the history, just think, right, something's not right here. This is not just a simple regurgitation after food that's, harmless. It's, something pathological going on here. So I've got a question here. Would you generally expect a fever in NEC? Not necessarily. I think NEC can definitely lead to hemodynamic instability, and it can lead to infection, I suppose, if there's perforation of the bowel. So yeah, it can definitely lead to fever, but you may not initially have the fever. So yeah, I don't think it's necessarily a make or break symptom, if that makes sense. But I think in that question as well, it helps you differentiate between sepsis and NEC, because you didn't have really that high a temperature at that point. Okay, I hope that all makes sense. So moving on. So this is question 10. And what do you reckon is the answer here? Try and refresh it this time. Tess, can you see any answers coming through? For some reason, I can't.
Not at the moment.
Not at the moment. Question.
Oh, someone says the slide hasn't moved. I can see question 10.
Oh.
That's weird.
Anyone else? Can anyone else see
Oh, now it has, apparently. Fine.
Oh, it has. Oh, sorry. It's probably my dodgy internet. So, oh, excellent. Yes, well done, Linus, smashing it. So yeah, sorry, I actually give people a chance to also get the answer. But yes, so that is the right answer there, so D. And actually, before I also go on to what we're actually talking about here, do we have any idea what condition we're talking about here? What springs to mind? Sorry, just refreshing again. Sorry, Tess, let me know if my the chat function doesn't really refresh that much on my thing. Can you just tell me if there's any answers there?
Someone has suggested pyloric stenosis.
Yes, well done, excellent. So yeah, I thought I'd ask about pyloric stenosis in a different way. So yeah, so basically, the reason why you're getting this abnormality in the blood gas is because the baby will be vomiting a lot, so that means that you lose the hydrochloric acid, and then this will start to impact the kidney basically, and that also leads to sort of hypokalemia. So this would be a few days along, basically, this kind of finding. Initially, you would probably get the hypochloremic bit. The hypokalemic bit also suggests it's been going on for a few days as well, because it's now starting to impact the kidneys. So well done for getting the answer right. So this is another really high yield condition to know about. Also, just again, important to know about in life. So what is it? It's basically a thickening of the pyloric muscle. And that results in a narrowing between the stomach and the small intestine. And then as this gets narrower and narrower, it's just going to lead to that really explosive projectile vomiting described as, hitting the walls. And that's also important in your OSCEs. Let's say you have a station where you're asking about vomiting, how explosive are we talking? Is it hitting the walls? And that will help you differentiate between worrying and less worrying causes of the vomiting. In terms of how common it is, fairly common-ish, and occurs more in males as well than females for some reason. Any risk factors, any causes? Again, didn't really find any clear associations there, but main risk factors include being male, firstborn, and also having a family history of pyloric stenosis. So in terms of clinical features, so yeah, it typically presents at 4 to 6 weeks. So that also helps you differentiate, what could be going on here in terms of the age. It's non-bilious, that's another key important fact there. So it happens above that anatomical point that I was talking about before. They'll typically present, dehydrated from all the vomiting, and they'll still be very hungry despite, losing weight, because they just can't keep anything down. In terms of examination findings, so probably on PassMed and all sorts of other resources, the classic thing you'll see is an olive-sized mass, which is very good for MCQ land, but I think in real life can be quite difficult to actually feel. But if you are going to feel it, it's probably best during when you're actually feeding them, and I'll go on to that in just a sec. You're more likely just to see sort of peristalsis of the tummy, basically, just it's like a little wave. But yeah, both can be quite hard to find, to be honest, though. So in terms of investigations you're going to test feed them with dextrose, and it's at that point that you might feel the mass around the pylorus, or you might actually see peristalsis. And in terms of ultrasound, you're going to see a hypertrophy of the pyloric muscle, and these are some specific numbers here to remember. I don't know if they test you specifically on that, but just so you know, that's the criteria that they'll be looking for. And like we said earlier, so the capillary blood gas would show a hypokalemic, hypochloremic, metabolic alkalosis because of all the vomiting. You're just losing all that chloride, and then eventually starts to impact the kidney. Right, and then that's what the ultrasound scan would look like. I feel like that, it's fair game, I suppose, if they might show you like an ultrasound scan, and hopefully be something quite obvious. I'm not sure how obvious I'd find this on out of the blue, but if you're revising, just have this in the back of your mind that this could be like an image question as well. And now you've seen it. Okie dokes. And then in terms of management, so initially you can sort of decompress the stomach by putting in an NG tube, and then it's always good to rehydrate, correct electrolyte abnormalities before any sort of surgical procedure, but ultimately they're going to need a surgical procedure to correct this. There's no other way really. So you just try and optimize them for the surgery. And the surgery is called Ramsted's pylorectomy, and that basically just opens up the narrow ring. And I think that's as much as you'll need to know about that bit of the management. So yeah, any questions at all at this point? If not, Tess, sorry, can you tell me if there's any questions at the moment?
None that I'm seeing.
Okay, excellent. We'll carry on then. So moving on to question 11. Any takers for the answer on this? Again, sorry if I'm not seeing the answers. For some reason, it's just not loading this.
There aren't any to see.
I can't tell if it's just me or...
But okay, someone suggested E.
Oh God, everyone's just so on it. So some of these were going to trip people up, but no, well done. So yeah, that is the correct answer. And I thought it was just quite a useful question because it just makes you think about all the key findings that you'd basically find with different causes of vomiting. So yes, Lauren, correct. E is the correct answer. And actually, moving on from that, what then do you think is the condition here that we're talking about? Again, this might just be me that I can't see it loading.
Got some intussusception suggestions.
Excellent, excellent. So yes, that is correct. So I suppose the key things in this history here is that it's the age. Age is very important here. The blood in the nappy. It's not quite red currant described here, but I don't think they'd be that nice to you. It's green vomiting, and there's a mass in the upper part of the abdomen. So yeah, well done. In terms of going through what all the other findings mean, so corkscrew appearance would be more in keeping with malrotation with volvulus. The portal venous gas on the abdominal x-ray and pneumatosis intestinalis, as we discussed before, is more indicative of neck. The hypertrophy of the pyloric sphincter is more in keeping with pyloric stenosis. And then I suppose by default then that leaves us with the target sign. So yes, Well done for those who got that right. So this is another very important condition to know about. I feel like it's quite a difficult one to visualize without actually seeing a picture, but it's basically when a section of the bowel telescopes into the next distal section, causing obstruction. And because of the way that the small bowel is basically less wide than the large bowel, the most common point for this to happen is at the ileocecal valve. And if untreated, this can lead to quite serious complications there, as you can see. And it's most importantly, it happens between the age of sort of 6 to 36 months, although peak incidence probably more like 7 to 9 months. And again, boys are more likely to be affected than girls. And these are just some images just to help you visualize what interception actually is. I didn't quite get it until I saw some images there, but yeah, you can see the top image there shows you where the ileocecal valve is, and then how the gut basically just telescopes in on itself. So in terms of what causes it, again, no clear cause. Sometimes there can be a lead point. So it basically just predisposes someone to having that weakness in that certain bit of the bowel. I'm not sure I quite entirely understand all of it, but it's things like Meckel's diverticulum, polyps, HSP, lymphoma. It can be post-operative, or it can also be associated with a preceding viral infection. But in most cases, there's not actually a real clear cause. In terms of clinical features, so you might, yes, they're going to be tired, they're going to sort of maybe draw up their knees and have these periods of sort of crying that you just can't calm them down. The pain is going to come as like sort of intermittent pain. The vomiting then becomes bilious in the later stages, and you get the red currant jelly stool. But this is actually quite a late sign, but I'm hoping they would include some of these features in the MCQs just for you to be able to recognise a bit more easily. And then in terms of examination findings, they might describe it as a sausage-shaped mass. That might be a bit too easy again, but just a general mass in the right upper quadrant area of the abdomen would help you think about the fact that this could be interception, distension, reduced absent bowel sounds, and dehydration again, all common things associated with vomiting. So yeah, here you can see a nice picture of the ultrasound scan findings. So if you look closely, you can see a kind of target or donut-shaped sign there. And then the lesser known pseudo kidney sign. I'm not sure I'd really know about that if I hadn't researched these slides, but the target sign I think is quite a common piece of information they'll give you in questions. But yeah, there's other investigations you should also do, but I think the ultrasound scan is definitely most important for diagnosis. And then in terms of management, so similar to pyloric stenosis, there's obviously a initial management that you need to do. You just need to resuscitate, and if they need fluid resuscitation, give that as required. Basically, need to make them just stable enough for surgery. So yeah, using NG tube to decompress the stomach, make them nil by mouth. And then in terms of definitive management, you don't actually need to start with surgery first, sorry. You can actually just start off with an air or contrast enema, and in 80% of cases, that should solve the issue. But if the air or contrast enema doesn't work, then you'll need surgery to reduce that telescoping, or if there's already dead bowel resection, unfortunately. And I think it's important so in that question, it actually showed that even though they were probably going to try medical management first, it's important to let the sort of paediatric surgeon just aware of the case, because it may quickly just turn into a case where they need to operate surgically. So yeah, always good to involve the surgical colleagues in this sort of scenario. Okie dokes, so moving on, we're nearly there. Final 2 questions now. So question 12, what did people put for this question? Any answers? Again, Tess, let me know if it's just me. Any takers? Oh, yes, okay. Liness again. Well done. That is the correct answer. And do you mind telling me why you put that answer? Sorry for picking on you. Yeah, exactly, DK. But I suppose some of the other responses are correct as well. But why would you go? It says initial management as well, which is an important part of the question. Yeah, exactly. Fluid replacement first, but actually in this case as well, she is starting to show signs of, I would say, shock in a way. Her blood pressure is dropping, her heart rate is, going high. She's drowsy. So actually, regardless of, basically with someone who's in shock, you need to give them a bolus first. And that doesn't count as part of the other types of fluids that you're going to give her. So you're not going to minus this off the rest of the type of fluids that you're going to need to give her. So yeah, she's in shock or approaching shock. We need to resuscitate her first with fluids. So yeah, well done. So I know you'll know DKA very well at this point, but I think it's an important one just to have just have at the forefront of your mind and to know the criteria very well. Have these figures in your mind. So it's in the name, the clue's in the name. So diabetic, associated with type 1 diabetes, ketones, so there needs to be ketones 3 in a gas or 2 and above on a dipstick, on a urine dipstick. There needs to be acidosis, so that's a pH of less than 7.3 and with a bicarb of less than 15. And the blood glucose also needs to be high, so above 11. In terms of what causes it, if you're interested, this is kind of the science behind it. But the underlying type 1 diabetes pathology is the autoimmune destruction of the beta islet cells in the pancreas, and that's going to lead to an absolute insulin deficiency eventually. And that leads to a rise in a bunch of different hormones. The blood glucose concentrations rise even further, and then that's going to lead to a rise in the ketones due to the breakdown of the adipose tissues. Then the combination of hyperglycemia, and glycosidic causes osmotic diuresis, and that is going to lead to the patient becoming very dehydrated. And then they're going to start vomiting as well, so it's going to worsen this dehydration, and it starts a cycle of just worsening acidosis until insulin is given, basically, to correct that hyperglycemia. So common factors leading to DKA, so it could be a new type 1 diabetes diagnosis, and that's how commonly DKA presents as. But it can also be due to non-compliance, device failure, changes in insulin requirements at puberty stages, maybe change their diet, so increase ingestion of glucose. Also can be during periods of illness as well. So there's a theme here with the vomiting. So you're gonna find that the child is lethargic, generally unwell, abdominal pain. If they've not already been diagnosed with type 1 diabetes, they might be showing signs of type 1 diabetes in the preceding weeks, and concurrent illness as well. And then I suppose some key examination findings. So the customized breathing, I think, is a very classic buzzword there. So you're going to find that really deep breathing, and they're just trying to get rid of the ketones. They're going to be breathing quick. In younger children, you might see the recessions in the ribs. You will also maybe see signs of shock, dehydration. This is also can definitely come up in an OSCE. In fact, I'm thinking of a station where this, just being able to recognize signs of dehydration shock, very, very important, both your written and your OSCE exams. And then D, reduced GCS, also worried about signs of cerebral edema. We'll go on to that in a bit when we look at the management guidelines. And then, abdominal pain and a sort of pear drops, smell, breath. That's another classic buzzword. That's due to the ketones. And in terms of how we investigate it, so we can get finger prick test, urine dipstick, blood gas. If you can do blood gas, make sure it's venous to be nicer. We don't need an ABG necessarily in this case. And then an ACG as well, especially as we manage this patient. So in terms of the management, so I took this off the Best Ped guidelines. Sorry if, I don't know if things have changed, but I feel like it still is very relevant. I know it says, yeah, version from 2022. Couldn't really find as good a diagram and just general layout of how to manage diabetes anywhere else. But as always, follow trust guidelines. And whenever you get someone with DKA, you will get a very nice pro forma to fill in. Basically, it will be laid out very nice and neatly for you, both in the paediatric and adult setting as well. So don't worry about remembering all of this, but I think it's important just to have at least the initial management steps at the forefront of your mind, and then you just basically follow the protocol basically as you go along managing them. So yeah, so you can see here, we just need to actually diagnose DKA. So like we went through before, the biochemistry there, the clinical signs, the clinical history, you're going to be able to diagnose DKA. And then it's important to know what, how the percent dehydration basically, because that's going to basically let you know how much fluid you're going to need to prescribe. And yeah, this will become relevant. So, and that's based on the pH there. So you can see pH 7.1, unless that's severe, 10% dehydration, 7.2 moderate, 5% dehydration, and then mild, actually it says 5% there as well. So that's what Best Ped says. Apologies if you might have other information there, but that's basically differentiate between severe and moderate DKA. And the reason why this is relevant is so you know how to calculate their deficit fluids. But before that though, like in this question here, you need to figure out, is this patient shocked? So things like tachycardia, prolonged cap refill time, poor peripheral pulses, and hypotension as well. So all those things are going to make you think, right, this patient is in shock, and you should actually give resuscitation fluids at a rate of 10 mils per kilo until their blood pressure is restored and they just don't seem shocked anymore. If they're not shocked, you can go straight on to the initial bolus, which I think some of you were talking about there. So 10 mils per kilo fluid bolus over 30 minutes. And you are actually going to take that out from the deficit fluid calculation. So it's going to count basically as part of that. So yes, I think it's basically with this sort of question, I think it's very relevant definitely for your written, but also for your OSCE exams. So just have a practice at trying different scenarios with this. Maybe I think it could come up as like a prescribing station. If you go on Teach Me Paediatrics, there's a really good example on there. So maybe have a look at that. If you type in DKA Teach Me Paediatrics, they've got like a worked example of how to calculate the fluids there, but I'll also talk through it now as well. So you can see there, the formula there shows you the deficit fluids, and you're basically going to replace that over a 48-hour period. That's what I know. You may see different figures elsewhere, but I think that's the right figure that I've been following at least. So 48 hours period. And then you're also going to calculate their total, their maintenance fluids as well. So also have in the back of your mind that, you know, once we start the fluid replacement, that's obviously what you need to do initially. You're then going to start the insulin at a rate of 0.05 or 0.1 units per kilo per hour, 1 to 2 hours after starting the fluids there. So moving on, so once you've started fluid replacing, then you've started the insulin replacement, you're going to basically want to keep a close eye on them. It's a very intensive process. You need to, you know, 1 to 2 hourly blood ketones, neuro-obs, fluid balance, and you basically just want to see, are we improving things in terms of the acidosis, the ketones, and the glucose? And hopefully after, you know, following the pro forma, you should get the blood glucose going before 14. And at this point, you want to change your fluids to 5% glucose. Before, you would have been using the saline with some potassium as well replacement. as you're going to give some insulin as well, it's going to reduce the potassium. So that's why you want to make sure that you're replacing the potassium, having them on the ECG as well as you're using, replacing potassium there as well. You want to see if you're, overcorrecting as well, and that will show in the ECG signs. And then once you've started to go below the 14, you then also don't want to go too low. So you don't want to start going below 6. And if that does happen, you then use 10% dextrose. But hopefully it should just all resolve. And then you'll be able to stop the IV insulin infusion and just go back to their normal regime. However, in the background, whilst all of this is happening, they should always have their long-acting insulin. So I realise it's very long, but I would just recommend just having a good look at this and just having it familiar in your head. And I think just at least knowing how to start the protocol is very important. And then from then on, you will have it all very nicely laid out in front of you, and you'll be able to follow it. So I wouldn't worry about remembering all of this, basically. So in terms of complications, we mentioned it briefly there, but things like cerebral edema, the hypokalemia as you're giving the insulin, and that can basically draw the potassium intracellularly. So you want to make sure that you're also replacing the potassium, and obviously hypoglycemia as well. You can really go the other way around. So just have these in the back of your mind as well when you're dealing with DKA. So on to the last question. Question 13. So any takers for this question? Any answers here? Still with me? It's the last one now, I promise. Ooh, okay. Melinda, you've gone with A. Anyone else have any other answers? A or D? Okay, it's a bit of a mixed picture here. So the reason why I picked this question is because I think it's very examinable. A, again, for your written, and also for your OSCEs as well. I think just having a general idea of UTIs, if they're typical, atypical, or what investigations do is quite important. Just very easy to test on. So actually it's C. And you'll find this actually, the NICE guidelines for this are pretty clear. Actually, it's really good for urine infections in paediatric cases. Basically just wanted to highlight this topic. It also comes under the abdominal pain, but just also very examinable. If you go on Teach Me Paediatrics, as you can see where I got a lot of this information from, they've got some really nice tables there which basically show what kind of investigations you need to do in children with UTIs, and depending on, whether they've, had a typical or atypical UTI, whether it's recurrent, whether it responds to the antibiotics. So you can see in this case, we had a 4-month-old, and they responded well to antibiotics. It wasn't an atypical UTI and it wasn't a recurrent one. So that means you're going to get an ultrasound scan within 6 weeks. So I know it's really annoying to have to remember all the stuff, but I could just see them testing on this. So just so we go through some important definitions here. So an atypical UTI would be any of these features here. I suppose a particular one to remember is the non-E. coli organism, but also if they don't respond to treatment within 48 hours. And then in terms of a recurrent UTI, you can see there 2 or more episodes of upper UTI, 1 episode of upper UTI, and 1 episode of lower UTI, or 3 episodes of lower UTI. So good just to have these in the back of your mind. And I suppose just a little expansion on the different types of imaging you can get. So ultrasound scan, very good for renal size and also identifying any abnormalities in the structure there. I would look up what these different scans look like. I'm really sorry, I just didn't have enough time to put different pictures here. But the DMSA basically helps with detecting renal parenchyma defects and scarring. And the MCUG, I'm not going to try and pronounce that word there, basically helps us identify reflux issues So yeah, that's the general base of why we do these investigations. But yeah, just have in the back of your mind the indications for these and the timing of when you do some of these scans. So I think that brings us to the end of our session. Thanks for bearing with us. So yeah, these are some very useful sources of information for peds, and also where I personally got a lot of my information from there. Head Smart in particular is very good for sort of brain tumour type information if you want to know a bit more, obviously relevant to what we talked about today as well. And the rest of them are a mixture of websites you probably already know about and also different podcasts as well, which are quite useful. So any questions at all as well at this point? Feel free to ask any questions, but if not, that's the end of the session. So we'll pop the feedback. I think it's already been sent actually, but we'll pop it in again. So if you can please provide some feedback, that'd be super helpful. And yeah, feel free to ask any questions at this point. Anything about the session, anything about exams. Yep, personally went to Leeds. I don't know if that's helpful for anyone. Happy to answer specific questions about that, or just general any other questions as well. So, but if not, yeah, you're free to go basically. And if you want any further information as well, these are our socials. But yeah, thanks for coming. Oh, Izzy, you said you can't find the feedback form. Is it just, if you scroll up, I think it's just in the chat. Forgive me if I'm wrong. Can everyone else see the feedback form link in the chat? If not, we can post like a link to it. Chat isn't updating. Ooh, okay, let me see. Do you by any chance source a link for us?
I'm not sure how I'm looking. So it's a valid question.
Because if I go off this, it just goes a bit glitchy when I. But
Yeah.
I don't mind trying as well.
I don't know how to get a URL because it's just like
if you stay
built
off,
into it.
I might my video might start getting a bit weird, but I'll try and get.
Well, it went glitchy, like she said. Oh, you've refreshed and you have it now. Perfect, Izzy. Vicky, have you seen this? It's all good.
And just for good measure, a little link here as well, just in case I found the link now.
Oh, nice.
Thanks everyone though.
Thanks everyone. Should we stop the live stream?
Let's finish then. Okay.
Amazing.